Welcome to another episode of the Osteopathic Lyceum podcast. What we're going to talk about here today is going to be a bit of a mishmash of things. A lot of it's going to be underpinned by the concepts of diagnostic reasoning. So one of the things that I've argued quite a bit before, or a point that I've attempted to make before, is that osteopathy, as far as its diagnostic procedures within the hands-on sphere, not necessarily for a doctor of osteopathy from America, but with respect to practitioners all over the world who are working hands-on, we are working from the external environment of observation with respect to the patient. So all of our tests are motion-based tests, whether we're using gross motion of a region of the body, whether we're using patient active, patient passive motion, whether we're using yield of pressure for soft tissues, or yield to pressure of soft tissues. We're imparting motion to things and getting proxy information about other things. So our tests are motion-based tests. So we're testing motion and we're interpreting things, or at least we're attempting to interpret things. One of the ways within the profession of osteopathy, and you'll find this in Foundations of Osteopathic Medicine, to interpret physical findings is to use the 5 models. So the biomechanical model, the respiratory model, the circulatory model, and so on and so forth, or whatever the 5 models are in specific. Those are not about the tests. The tests are the tests. They test motion, that's it. Within the profession, however, there is the desire to interpret through those lenses, or there is at least a suggestion. Now, what I would say with respect to validity, or a test being what it says that it is, if you use those 5 models to interpret, you're probably making mistakes that you don't know about. If you use the motion finding as the test itself and simply note that this thing is not moving appropriately, especially when compared to a paired structure, so the right arm is moving different than the left arm, you're valid. That test is what it says it is. It is comparing freedom of motion from one thing to a similar thing. Similar would be the case for soft tissue testing. So you press into a soft tissue and one portion of it yields as everything else does, and then there's a notable portion that doesn't yield. Well, you notice a difference in motion, so it's a motion test. So the errors that are available on a fundamental level within that 5 model framework are the interpretive steps, right? So when you reduce the amount of interpretive steps, you reduce the complexity, reduce the cognitive load, but you can also reduce the accuracy in some ways. So I can see the argument for maybe more accurate interpretation, but I think the most accurate interpretation of a motion test is to report the motion finding, especially compared to a paired or similar structure. So to move through this a little bit, so instead of saying simply that we should ignore the 5 model framework, or we should ignore varying interpretive frameworks such as cranial or visceral, what I'm going to talk about is the process of diagnostic reasoning and how errors develop and how you can improve it, and depending on how you teach at the fundamental level, how things tend to work better for the practitioners across time, or at least maybe not across time, because I don't know that there's been enough time to appropriately develop these concepts from the basic novice level testing. But the basic novice level testing shows a very, very specific phenomenon that does relate well to an expertise-based phenomenon, or a phenomenon that you will identify in experts with respect to near versus far transfer. So there's a lot of things kind of going on here, and I'll do my best to weave some of this together. But one of the things that the 5 model framework is attempting to do is give you a clinical impression of a system, right? So the respiratory system, or the respiratory circulatory system, or the cardiovascular system, however you want to term it. But basically, it's going to give you this opportunity to have an impression based on motion findings. Now, the problem is that an alteration in motion doesn't always relate appropriately to an underlying function. Sometimes it's just a difference in motion. And let's just say if you use the respiratory circulatory model as an example, let's say the right shoulder doesn't move as well. That doesn't mean something is happening to the liver, the gallbladder, or the right lung. It doesn't mean that. It could mean that under the appropriate set of circumstances. Usually you're going to be more accurate when there was major trauma to the right side of the thorax. So it's not that the right shoulder is moving poorly because of the lung or the liver or the gallbladder, or that the liver or the gallbladder are not functioning properly because of the lung. It was trauma, right? So you're more likely to have an appropriate relationship between physical findings or superficial physical findings and deeper things when there's more obvious trauma, or there's a longer standing issue that was congenital in nature. But to take physical findings and turn those into a systems-based impression is not appropriate. However, it gets better when you get context from the patient. So when the patient says, "I'm having a hard time breathing, and when I eat bacon, I get really, really strong digestive discomfort," and then you have the physical finding of the right shoulder or the ribs on the right not moving as well. Well, now you can start to piece it together and build your clinical impression that, okay, the anatomy in this area is showing a lot of problems, and they're providing symptom reports that would relate to underlying functions. So realistically, with respect to osteopathy, your symptom reports from the patient give you more insight than your physical findings do to what's going on, quote unquote, under the hood or physiologically. The physical tests, the motion tests, do not give you much information other than the finding of the motion test. When put together in context with the symptom report of the patient, sometimes you get a better clinical impression that something else is going on. But let's just say there's a digestive issue. You're not going to be correct about the digestive issue as often with respect to motion findings that would relate to the region as you are with the symptom report. So the symptom report of the patient is going to tell you more about the physiological reality for an osteopathic hands-on practitioner than the motion test is. Or maybe a way that I should say that better is the symptom report will tell you about the internal physiology better than your superficial motion findings, right? So maybe that's a better way to put it. Anyways, in order to move on so that you understand this a little bit better, I'm going to share my screen and go through a few things here. So what we want to talk about, where'd you go, is essentially diagnostic accuracy, and clinical decision-making, and diagnostic, not necessarily decision-making, but maybe a little bit more about accuracy. So what we have presented here is a paper. This is from 2012. It's the relationship between response time and diagnostic accuracy. So the reason I need to do something before talking about this is because there's this thing that many people will have heard. Some won't, but if you've looked at clinical reasoning, diagnostic accuracy, you would have come across system 2 and system 1 and system 2 thinking, or thinking fast and slow, or what's system 1 is the fast heuristic based, and system 2 is the slow, more reasoning based system. This comes out of the work of Daniel Kahneman and Amos Tversky. The thing that almost everybody would have heard that springs from that work is the term bias, or cognitive bias. Now, cognitive bias as a term is something that in common vernacular gives me major issues, because realistically what a cognitive bias is a fancy description, and there's tons of them. You can look this up anywhere. You can say list of cognitive biases. And essentially what you're going to identify when you do that is that it's going to be this big, long list of mistakes in thinking that the people who are thinking don't know they're making. So a bias, or the term bias in common vernacular, is often used when really what people are attempting to say is preference. Somebody prefers one thing over another. But a cognitive bias, taken technically, is a mistake in thinking that the thinker doesn't know they're making. So anyways, that's just there's this longer standing belief that your errors are more from the system 1 fast thinking. There, at least in healthcare, at least in medicine, there have been some experiments done to challenge this concept, or not challenge this concept. The findings challenge this concept. The findings of this research challenges the system 1, system 2 concept or model with respect to clinical accuracy and clinical reasoning, or diagnostic accuracy and reasoning. So I'll read from the abstract here. Or first, I'll name the paper. The relationship between response time and diagnostic accuracy. The abstract, the purpose. The psychologists theorize that cognitive reasoning involves 2 distinct processes: system 1, which is rapid, unconscious, and contextual, and system 2, which is slow, logical, and rational. According to literature, medical According to the literature, diagnostic errors arise primarily from system one reasoning, and therefore they are associated with rapid diagnosis. This study tested whether accuracy is associated with shorter or longer times to diagnosis. So an important thing here is that they took the basic prediction of system one being a faster output, right? And they said they wanted to relate that to actual diagnostic accuracy. So they provided a diagnostic task and they just measured time to output and then related time to output and accuracy. And the essential finding is that the faster somebody diagnosed or the faster they had their output, the more accurate they were. What that also related to, and what I'll read the results, 75, so that I'm going to read the results so that I can put this together a little bit more accurately. 75 Canadian medical graduates of 95 potential participants participated. The overall correlation between reaction time and accuracy was negative 0.54. Accuracy then was strongly associated with more rapid response time. This negative relationship with response time held for 23 of 25 cases individually and overall when the authors controlled for participants' knowledge as judged by their MCCQE Part 1 and 2 scores. For 19 of 25 cases, accuracy on each case was positively related to experience with that specific diagnosis. A participant's performance on the overall test was significantly correlated with his or her performance on both the MCCQE Part 1 and Part 2. So that's the MCCQE is a standardized test. But basically, what they're noting is that if somebody has been familiarized with a specific diagnosis before, they're faster to diagnose with it again because they have seen it before. And also the accuracy, the faster you responded, the more accurate you were. So experience made you faster, which means that knowledge made you faster and more accurate. So the conclusion, I'll read from their conclusion just so it ties it up their way, and then I can make some mild commentary. These results are inconsistent with clinical reasoning models that presume system one reasoning is necessarily more error-prone than system two. These results suggest instead that rapid diagnosis is accurate and relates to other measures of competence. And so this was an earlier foray into this field with respect to clinical reasoning, diagnostic accuracy, and things of that nature. So the existing models that would broadly suggest that there is a skill that is abstract called clinical reasoning or diagnostic reasoning probably isn't the thing that we think. This actually relates well to the concept of critical thinking. I've done an episode on critical thinking in the past, and that was, I believe, episode 8 of the Osteopathic Lyceum podcast, if you want to look at that and hear about how critical thinking really isn't an observable thing, at least with respect to psychological experiments, but philosophers really like the idea. But it's not you can't operationalize it and identify it. Really what you see when you're looking for critical thinking is experts and novices and the difference between them, if you see anything at all. But that also relates to clinical or diagnostic accuracy. So we're going to go and try to go through some of the other papers here and find a little bit more about that so I can point to it and make sure this one. So this is actually another thing that relates well to what we just noted. Now, this came before. So this one came from 2006. So this is before the one that I just spoke about. So the other one was 2012. This one is the value of basic science in clinical diagnosis. All right, this is from 2006. Yeah, so I'll read the full abstract. The background: the role of basic science knowledge in clinical diagnosis is unclear. There has been no experimental demonstration of its value helping students recall and organize clinical information. The study examines how causal knowledge may lead to better recall and diagnostic skill over time. The reason this would have been important in 2006 is because there's been this long-term underlying assumption that people knowing basic scientific mechanisms would help them with their clinical skills, their clinical reasoning, their diagnostic accuracy, things of that nature. So this was one of the first forays into trying to figure out if it did help. Okay, so the method: undergraduate medical students learned either 4 neurological or rheumatic disorders. One group learned a basic science explanation for the symptoms. The other learned epidemiological information. Both were then tested with the same set of clinical cases immediately after learning and 1 week later. The results. On immediate test, there was no difference in accuracy, 70% for both groups. However, 1 week later, performance in the epidemiology group dropped to 51%. The basic science group only dropped to 62%. So the conclusion, which is relatively obvious from the result, basic science knowledge relating causal knowledge to disease symptoms can improve diagnostic accuracy after a delay. So what they noted is that after what would be termed a washout period or a latency period, that the initial similarity, so when you learn something that's fresh, you often will perform well. However, when delayed, when people leave you alone, performance can change depending on varying factors. The findings suggest that when you integrate basic science knowledge with a medical diagnostic or a medical diagnostic procedure or a medical diagnosis, that the improvement stays better longer, right? So there's better retention and recall. One of the things that may relate to is what's called a semantic network or a network of related meaning. So the way to leverage that in a profession like osteopathy is not to learn anatomy or learn physiology simply to learn anatomy or physiology. It is to relate them to those things that you are actually testing and finding. In osteopathy, the central feature that you're testing and finding is movement. So if you relate anatomy to a movement, such as cervical flexion, cervical extension, and cervical side bending and rotation, so let's just take that as an example. For cervical flexion, you would have the muscles that flex the cervical region. You would have the nerves that would activate those muscles. You would have the blood vessels that move blood in and out of those regions, and you'd have lymphatic correlates. You'd also have physiological topics that would make sense in the region, right? So let's just say the thyroid, something of that nature. Cervical extenders, now it's another set of muscles, but fairly similar nerves and somewhat similar blood vessels, although obviously different in specific detail, but the branches or the places they originate are very similar. So there's some redundancy. Now, when you get to cervical side bending and rotation, what it is, it's the flexors and extenders on one side of the neck. So there's redundancy there. So if you do anatomy and physiology relating to the movement, then the central point of the semantic network or the network of related meaning is the movement, right? So you're integrating basic science of anatomy and physiology to the movement, and you're also noting redundancy between movements. So flexion and extension generate when one-sided, side bending or rotation. So you have a huge amount of redundancy, a huge amount of connected meaning based on motion, because that's a salient feature of the practitioner. So when you start to integrate those things, you can leverage this phenomenon of integrating basic science. Now I'm going to share a different screen so that I can go through a few different things. And hopefully this is the correct one. I believe this is the correct one. Okay, yeah, there we go. I'm going to move this just so I can get to what I need to get to here. Hold on. Please excuse me while I just try to wiggle this around more appropriately, and it won't let me. Of course it won't let me. Then I'll just do this. Okay, so the three phases of clinical reasoning, I'll make this larger so that it's more visible, because now I can kind of get through it. Okay, so should I do this one first? Yeah, I'll do this one first. So this article, three phases of clinical reasoning, epistemological explanations of disparate error reduction strategies. So again, I just want to reiterate that the reason I'm going through this is to talk about clinical reasoning, to remind you that critical thinking is not a thing. You can look at the Osteopathic Lyceum podcast, episode 8, if you want to learn more about why it's not a thing, but it's also contained within some of this information as to why it's not a thing, because it's much more about specific details and then developing a framework for interpreting those details. Now, somebody can provide you with a framework and provide you with details, and then that does a better job. So that's why when teaching things, you would want to develop it that way in a more integrated fashion. And I'll talk about that with respect to transfer as we move on. So near transfer versus far transfer and why that's important and how that maps well onto what I'm showing you here with respect to clinical reasoning, diagnostic accuracy, diagnostic reasoning, things of those nature. This relates well to the first paper with respect to System 1 and System 2 thinking. So I'll read the abstract here. There's a general consensus that clinical reasoning involves two stages: a rapid stage where one or more diagnostic hypotheses are advanced, and a slower stage where these hypotheses are tested or confirmed. The rapid hypothesis generation stage is considered inaccessible for analysis and observation. Consequently, recent research on clinical reasoning has focused specifically on improving the accuracy of the slower hypothesis confirmation stage. Three perspectives have developed in this line of research. Each proposes different error reduction strategies for clinical reasoning. This paper considers these three perspectives and examines the underlying assumptions. Additionally, this paper reviews the evidence or lack of behind each class of error reduction strategies. The first perspective takes an epidemiological stance, appealing to the benefits of incorporating population data and evidence-based medicine in everyday clinical reasoning. The second builds on the heuristic and bias research program, appealing to a special class of dual process reasoning models that theorizes a rapid, error-prone cognitive process for problem solving with a slower, more logical cognitive process capable of correcting those errors. I'm just going to pull out for a moment. That's the System 1 and System 2 thinking that we've already talked about. Finally, the third perspective borrows from an exemplar model of categorization that explicitly relates clinical knowledge and experience to diagnostic accuracy. That last sentence points to, in part, the result from the first paper that we noted, that increased speed and accuracy relates well to familiarity with the diagnosis, previous experience with the diagnosis, and things of that nature. So within this paper, I'm not going to belabor this, but essentially the first 2 points, that the more classic views on clinical reasoning. Hold on. Let me just name them for you properly. The epidemiological stance, population data, evidence-based medicine, that just doesn't seem to work for error reduction or improving diagnostic accuracy. It's not that it doesn't inform it at all, but that strategy, as it would be laid out properly in this paper, just doesn't seem to do a ton with respect to diagnostic processes as far as reducing errors. The System 1 and System 2 cognitive debiasing type approach essentially does little to nothing for reducing medical error. And one of the rationales for that is the underlying assumption of debiasing, or the cognitive bias approach in the System 1, System 2, is that you're aiming at the person who made the mistake. So the person who made the mistake in thinking that you're going to develop a strategy around did not know that they made the mistake in thinking, so they're going to not be a good target for identifying their mistake. The third perspective that they note, like an exemplar model of categorization explicitly relates clinical knowledge and experience to diagnostic accuracy. So essentially what they're talking about there is what I've brought up before, semantic network. So there are central features that have a bunch of detail nodes, and those detail nodes will relate to other central features. So something such as, let's just say, type 2 diabetes might relate to in your brain, right? So you've got type 2 diabetes as a central piece, and then you can have things such as the circulatory system, like diabetic feet, right? So the circulatory system, insulin, the pancreas. You could then have things such as blood glucose levels that could make you think of finger pricks. Finger pricks could make you think about other blood collection methods, right? So you can start to think about this. And then that would relate to varying things, right? So for an osteopathic practitioner, somebody complains about numbness in their feet, right? Then a question is, do you possibly happen to have type 2 diabetes, right? So you can see how these things start to mesh together as separate things. So numb feet could mean something such as, a long-term neuropathy, but it could also, that long-term neuropathy could be from type 2 diabetes. So you can see how these start to mesh together. If you haven't been introduced to those things separately or in a way that would allow them to relate, you don't relate them. But expertise or the acquisition of more knowledge across time helps these things start to mesh. So essentially, as far as clinical reasoning, experience and specific knowledge go well together so that you start to bring your semantic networks together. Now, there are errors that experts tend to make, but experts do make less errors than novices. And it's really likely that cognitive process that's really detail and experience oriented. So experience is a detail. Okay, so I'm going to move on to another paper here for a moment. So you can see how that semantic network concept does a pretty darn good job helping us out, right? So that related meaning. So as I noted before, the network of related meaning within osteopathy is likely well suited to being centered on motion because we test motion, we observe motion, we have motion findings. This is from 2018, so I believe this was a little bit after. Critical thinking, biases, and dual processing, the enduring myth of generalizable skills. Yeah, so basically this paper, what it does is it goes through, and I'm not going to belabor it, but it goes through and it points to where these generalizable skills, right? So learning Latin to be a better thinker, it just doesn't pan out. Critical thinking doesn't pan out. Detail-based thinking and details that relate to varying things across time does really well. So the semantic network approach does a really good job across time because, again, experts build a better semantic network or a better network of related meaning between specific details or specific concepts. There's something down here that I was hoping to read. It's going to give me a little bit of delay because my computer's going to go slow, but that's okay. I can ramble a little bit here. Yeah. Sorry, I'm just briefly scanning here. Where is it? I'm going to read the conclusion. Yeah, so I'm going to read the conclusion here. We've shown that the current models of reasoning and thinking popularized in medical education perpetrate a theoretical, I think that should be perpetuate. I'm not sure, but it could be perpetrate. That just messed with me for a moment, so please excuse that. We've shown that the current models of reasoning and thinking popularized in medical education perpetrate a theoretical position that is inconsistent with the evidence accrued for over a century in psychology and half a century in medicine. There is no justification for the position that knowledge-rich, efficient strategies as used by experts can be viewed as inferior to general analytical and rational approaches. We are not the first to challenge the assertion that rational generalizable rules are more effective than heuristics derived from case-based experience. Dreyfus, acknowledged as the guru of artificial intelligence, wrote, "We must be prepared to abandon the traditional view that runs from Plato to Piaget, Chomsky, that a beginner starts with specific cases and, as he or she becomes more proficient, abstracts and interiorizes more and more sophisticated rules. It might turn out that skill acquisition moves in just the opposite direction, from abstract rules to particular cases. The deification of rational decontextualized strategies is consistent with some claims that they represent an evolutionary adaptation from contextualized heuristic approaches. It would be a marvel indeed if human cognition were able to evolve purely through mental effort. In the current era of specialized expertise, there's every reason to challenge the assertion we introduced at the beginning of this paper that the central focus of education should be to inculcate general skills like critical thinking, problem solving, clinical reasoning, and reflection. Perhaps Homo sapiens, wise man, should be replaced by Homo science, knowing man at the apex of evolution." That's a little editorialization. That's okay. But I think the thing here is that, or the important point is, the generalizable skill is not necessarily something to attempt to teach. Sometimes the specific skill is the thing to teach. Now, what I will say is that experts, so I'll talk about transfer for a moment to try to make this point. Near transfer is, or transfer is essentially the ability to learn a skill or concept in, or a skill or piece of knowledge in one context and apply it in a dissimilar context. So that dissimilarity could be very small or it could be very large. The smaller the dissimilarity, it will be called near transfer. The larger the dissimilarity, it will be called far transfer. Far transfer is so dissimilar that the thing that you're applying is often difficult to actually see, touch, hear, smell. It's very different. So far transfer is better characterized as intangible concepts that are stable between contexts. So the ability to control a patient in hands-on therapy is omnipresent, right? So it's going to be some mix of the table and the practitioner generating that control, such that the same the same concept applies in seated, as in supine, as in prone, as in lateral with respect to the table, but the actual way that you develop the control has major differences in detail depending on the patient position, right? So this is why I put forth heuristics, which would be your omnipresent feature or your omnipresent concept with respect to controlling a patient. And one of the ways that I've done that is I say contact is control and control is safety. So the more contact you have with the patient, the more controlled they are, the less uncontrolled movements happen, the safer they are. Now we translate that into the patient positioning heuristics. The table makes stable. The more of the patient that is in contact with the table, the more stable they are. Less stable means I, the practitioner, need to make the patient more stable. Well, now we have a problem. So less stable. So if I put them in lateral, there's less of them in contact with the table than in supine or prone. So how do I deal with that? Well, the space between us is unstable. So any space between myself and the patient allows for uncontrolled movement, which means that I should be closer to the patient or the patient should be closer to me, right? So space between is unstable refers to negative space or that empty space, right? So you can see how these start to come together. And although the table makes stable seems like a really relatively straightforward concept, it's trying to tell you something deeper, that you need to control the patient in different ways depending on the position, which means that it's an abstract, intangible concept until you note how it's done similarly in many different places. Now, the way to get to that is you must explicitly note the intangible thing. So you note the heuristic or you note the concept that's the same regardless of patient position, and then you provide examples. A minimum of 2 examples, explicit examples of the explicitly noted concept improves the ability to utilize it for novices. FAR transfer is, when you don't do that, when you don't optimize for FAR transfer, you see FAR transfer in experts, so you're not seeing FAR transfer or the ability to abstract as such, you're seeing an expert. So it's better in experts. So what you're seeing is the process of accumulating expertise, showing the ability to the skill of abstracting more. So it does show abstracting. You're seeing it showing the skill of abstracting better, but it's not because of instruction. It's because they've, across time, gone from novice to expert, right? So this paper I'll touch on exploring cognitive integration of basic science and effect on diagnostic reasoning in novices. And the abstract will do what we need. The abstract will do what we need here. So I'll read the abstract. And you can see that when I talk about near transfer versus far transfer, especially in novices, when you do things in very specific ways, you improve transfer, not necessarily far transfer, but you improve transfer or you improve knowledge retention at minimum. And one of the ways to do that is to build a semantic network or build familiarity with things so that you can pull out, so that you've kind of got multiple things in a network of meaning. So in osteopathy, as I've suggested, the network of meaning would ideally be centered around motion or specific motions. Therefore, there's a lot of redundancy between them, so you can start to pull between and you'll solidify that knowledge better, and that knowledge will move between networks better. So the abstract here, integration of basic and clinical science knowledge is increasingly being recognized as important for practice in health professions. Concept of cognitive integration places emphasis on the value of basic science and providing critical connections to clinical signs and symptoms while accounting for the fact that clinicians may not spontaneously articulate their use of basic science knowledge in clinical reasoning. In the study, we use a diagnostic justification test to explore the impact of integrated basic science instruction on novices' diagnostic reasoning process. Participants were allocated to an integrated basic science or clinical science training group. The integrated basic science group was taught the clinical features along with the underlying causal mechanisms of 4 musculoskeletal pathologies, while the clinical science group was taught only the clinical features. Participants completed a diagnostic accuracy test immediately after initial learning, and 1 week later, a diagnostic accuracy and justification test. The results showed that novices who learned the integrated causal mechanisms had superior diagnostic accuracy and better understanding of the relative importance of key clinical features. These findings further our understanding of cognitive integration by providing evidence of the specific changes in clinical reasoning when basic and clinical sciences are integrated during learning. Right? So the novices who learned, to return to the sentence, the novices The results showed that novices who learned the integrated causal mechanisms had superior diagnostic accuracy and better understanding of the relative importance of key clinical features. So that integrated approach, integrating the thing that you want as your central piece of meaning and information about it on a basic level, improve performance at delayed periods or after the fact. Initial learning, especially for the identification of a thing, which is what you'd be looking at in diagnostic accuracy, is similar between groups. However, the ability to deal with it later and do a better job later improves when you integrate it. All right, so I'm going to stop the share. I'm going to do that, and it's going to work. There we go. Okay. So I've provided a decent amount of evidence from, or at least a superficial amount of evidence from varying angles with respect to developing diagnostic understandings, diagnostic accuracy, skills, clinical impressions, things of that nature. I've talked about the validity of motion tests being meaningful when you're talking about motion as opposed to when you're trying to talk about other things. So what I'd like to do is attempt to sew this together, also the semantic network, right? So as an osteopathic hands-on practitioner from the external environment of observation, you are not gaining information from osteopathic intervention, osteopathic assessment about internal processes in a meaningful way. You are gaining, at best, very blunt proxy information about internal processes or physiology. You are gaining exceptionally accurate information about movement characteristics in the moment. So to be valid, you speak about the region where the movement is lacking, often because it becomes more evident through the treatment if you are testing and retesting with the same test that one thing or one intervention did not work appropriately, but another one did. You get even closer to where at least the identifiable movement dysfunction lives more. So let's just say I take this the shoulder girdle, right? And I find a dysfunction within the shoulder girdle. A relatively standard way to go about it is you think about the medial border of the scapula, the lateral border of the scapula, and then what I would call the anterior border or the pec. So, pec major, pec minor-ish area. So if I explore the medial border, I find some dysfunction and I treat that and I retest and the shoulder girdle is moving as it should, then it was very likely some of the tissues on the medial border of the shoulder blade or the medial border of the scapula. If that doesn't work, and I go to the lateral border, so I think more teres major, teres minor, infraspinatus, latissimus dorsi, triceps. If I'm working in that area, then I can start to narrow down to there. So that clinical impression improves as far as region. So let's just say I treat that, and then now the shoulder girdle moves as it should. Then I think it was one of those. I don't know which one necessarily, but I know it was in that region. If those don't work, and then I go to the anterior border, and I work on the pectoral tissue, and then that lets it all go, then I believe it was more on that anterior portion. Now, interestingly, if all three of them gave me some level of improvement, then it was all three of them, right? That's the information or an example of the information that you can glean from the osteopathic assessment, osteopathic treatment approach, especially if you're reassessing consistently with the same initial assessment. You start to be able to narrow that down. Anything else I want to say is guesswork at best. So even that 5 model approach is just an interpretation. It's a story that I'm going to make up after the fact. But if I am appropriately integrating the knowledge of physiology and the knowledge of anatomy with particular movements, then I can be pretty good with the anatomy. I can be okay with the physiology. The physiological claims are going to be much less accurate. They're going to be much less valid with osteopathic assessment, but they will be decent if in context, when gaining information from the patient, when discussing things with them, and they provide you with information in your intake or throughout the treatment as things pop in their mind, the context of the symptom, the context of the report that only the patient can sense will allow you to have some ability to connect these things. So your ability as an osteopathic professional to learn anything about the internal state of the patient depends on the patient report. So that must be accurate. You must assume that it's accurate. And you really have no choice other than to assume it's accurate, such that any physical intervention on the osteopathic level from the external environment of observation that you provide at best relates to patient report. If patient reports change in internal state that only they can sense, then you can have some low level of confidence that your assessment findings, that your treatment that created change in motion relate somewhat to that, at least in time. But to believe that it causally relates to it is actually very difficult. There are times when you can build that up a little bit better. Now, that said, the errors in clinical reasoning for an osteopathic practitioner are much easier to make when you're going beyond a valid interpretation of your test, when you're utilizing common osteopathic models to make claims about internal states based on physical findings. So those physical findings can be very accurate, but the cranial model has huge flaws in its fundamental rationale. The visceral model has huge flaws in its fundamental rationale. The five models approach has huge flaws in its fundamental approach. And one of the major flaws, not in a bad way, is that they rely on patient report. Patient report must be trusted because these patients are real people and you can't get inside of their sensations. There are unfortunate realities that there are times when people are either not paying attention or they are misreporting, which is unfortunate. It's often not malicious. Sometimes it's just differences in communication, right? So it's not to sit here and say anything negative about the patient, but patient report has challenges with its level of accuracy, especially with relation to clinical states and clinical findings, right? So there are challenges with it. So that's a fundamental flaw of most interpretive models, especially from the external environment of observation. So if your central network, or your central network of meaning, or your central point of your semantic network is a model that has flaws in it, such as the five models, such as cranial, such as visceral, such as fluid-based models, whatever you want to talk about. If they have those errors and that's your central point of meaning, you're going to have major problems in your interpretations of physical findings. If movements, or I would argue that if movements are the central point in your semantic network or your network of related meaning, you're going to be much more accurate because that relates much better to your actual clinical approach in osteopathy, which is testing motion, be it gross motion, patient active, patient passive, or yield to pressure of soft tissue. You're going to be accurate there. You'll be better at being accurate to the region because your understanding of anatomy is going to be a little bit more central to it. You're not learning the anatomy just to learn anatomy. You're learning anatomy in relation to particular motions. So when you test, shoulder flexion, when you test shoulder abduction, when you test cervical side bending, you're going to have a better relationship with the tissues and the nerves and all that that's going on. So your ability to build a clinical impression of a region that's in danger that you need to send out for further diagnostics by somebody who can get that internal picture, be it radiology, be it blood work, whatever it is, you'll know better when to send out. You'll know better when to work well with other healthcare practitioners because you are centering your network of meaning around what you actually do. Osteopathic practitioners don't do anatomy. Anatomists do anatomy. Osteopathic practitioners do movement. We use movement to test. We use movement to treat. We use basic assumptions about how people will respond to alter the motion with very minimal negative clinical outcomes. And that's guided by the barrier concept. So as far as why you would build a program of knowledge a particular way for clinical understanding, clinical interpretation, clinical assessment, relates very well to models of moving from novice to expertise. You get novices better at being novices and moving towards expertise by integrating basic science with clinical stuff, right? So in osteopathy, my basic argument would be that the thing that you really want to center all of your teaching around is specific motions. It's one of the easiest ways to break it all up into manageable chunks. So shoulder flexion, shoulder extension, shoulder abduction, shoulder adduction, scapular elevation, scapular depression, things like this. Plantar flexion, dorsiflexion, knee extension. If you center around those movements, then there's a huge amount of redundancy and crossover. You get a lot of information and it goes really well, really easily, as opposed to centering on anatomy, then centering on physiology, then centering on clinical cases. Put it all in one in osteopathy. I would suggest movement being the big deal. And this will also relate well to actual clinical approaches, and this will relate well to understanding where things are and what might be going on and when you need to refer out. So hopefully that was useful, and we'll talk again soon.